And this applies to things like diabetic nephropathy, vasculitis, IgA nephropathy, etc., where we have these descriptive diagnostic categories. And so the broad principle is that can we sort of split these out using predictive biomarkers and the molecular knowledge that we're gaining in these diseases to put them into much more individualized groups, and then those treatments that you can apply that we have will be applied to the right patient at the right time according to their molecular and a sort of definitive pathological diagnosis. So currently we treat patients as I've put it on the slide, treatment A followed by treatment B followed by treatment C. So it's a kind of iterative, we try one thing, if it doesn't work, we try the next until either something works or the patient falls over or gets side effects. So next slide. So how do we apply this to nephrotic syndrome? I think, so I'm not going to talk predominantly about the clinical features of nephrotic syndrome. I hope that you've all got a good idea of this, and this is just a medical student teaching slide of nephrotic syndrome, where you get leakage of protein leading to hypoalbuminemia and all the sort of clinical symptoms that we're familiar with. Next slide. So currently, I'm a pediatric nephrologist, but both in pediatrics and adult medicine, we tend to classify the disease according to a descriptive algorithm. And so in pediatrics, we tend to use steroids response as our descriptor. And again, you'll be familiar with this kind of algorithm where you have patients who are either steroid sensitive or steroid resistant, and they're subdivided into various different groups according to their response. The group I'm going to focus most on today as an illustration of how we're working on this is the steroid resistant group. So this is the group that is the most difficult that we have in terms of treatment, and arguably one of the most difficult groups of patients in nephrology to treat when judging by some of the patients we see who have multi-drug resistance, etc., get to transplant and get recurrence of disease post-transplant. So it's an interesting disease biologically, but also a difficult disease clinically to treat. And these currently are divided, or one way of dividing them is into primary, secondary steroid resistance, and then presumed resistance is the ones that we think are primarily genetic, and I'll talk about those as we go on. So next slide. And the other classification, and again, this is more often used in adult medicine because all patients who present tend to get biopsied, is by histology. And again, histology is purely descriptive, as you can see by the names that we apply. So minimal change or focal segmental glomerulosclerosis, FSGS, effectively describes scarring in the kidney. It doesn't tell you the underlying molecular pathology. And then there are others such as membranous and MPGN and so on, which again are descriptive based on light and electron microscopy. And my argument is that this is it's both imprecise and it's also potentially dangerous. It's not fit for purpose in terms of how we treat our patients, and we need to get to a much more nuanced way of knowing what the underlying condition is. So next slide. So in order to understand that, I make no apologies that I'm going to take you through some biology, and we need to really understand the basic biology in order to sort of know where we're going and how to start to reclassify these diseases. So the nephrotic syndrome is based on the glomerulus and damage to the glomerulus, and specifically to the glomerular filtration barrier. And what you see highlighted is the filtration barrier, which is made up of, if you look at the electron microscopy at the bottom, of a tri-layer of cells on either side and a basement membrane in the middle. And sitting on the basement membrane on the capillary side are the endothelial cells, and on the urinary side are the podocytes. And you can see the sort of complicated architecture and the sort of regular architecture of the podocyte, both in these electron microscopy images. And I haven't got a pointer, I'm afraid, but if you look at the sort of dark areas surrounding those foot processes on the bottom panel, those dark lines represent the actin cytoskeleton. So that's actin, which is forming a scaffold for the structure, the complicated structure of these podocyte foot processes. And this is the structure that underlies both the integrity of the filtration barrier, but also what goes wrong when these structures are destroyed in any form of nephrotic syndrome. So next slide.
Mo, and you can use your mouse as a pointer if you want.
All right, can you see that on the screen?
You should be able to. Maybe not. Okay.
If I'm moving it around, because somebody else's screen is being shared, so that shouldn't.
Sorry, that's Kate. Yeah. Okay.
Yeah. So I don't think my mouse will show up. Yeah. So I'll try and sort of try and describe which bits I'm talking about. As we get to some of the data slides later on, I may struggle. This is a cartoon of the podocyte slit diaphragm. So this is really homing down on those foot processes of the podocyte and a cross section across those foot processes. And what you can see is that the nerve center of what I call the podocyte is this slit diaphragm. Thank you for thank you for the arrow. The slit diaphragm in between, this sort of cell-cell junction between adjacent podocyte foot processes. And over the years, we've discovered lots of important proteins that sit in this effectively huge molecular complex of proteins. And some of them are completely podocyte specific. So for example, nephrin, which is shown there in green, and podocin, which it binds to, which is in blue, are completely podocyte specific. They don't exist in any other cell type in the body. And this gives the podocytes its specificity, and this signaling complex then signals to that actin cytoskeleton, which I mentioned, which forms the sort of scaffold and the dynamic structure of the podocyte. And one key lesson about the structure is that it is dynamic. The podocyte can change its shape or pretty much all the time. And there's theories that the podocyte can move along that basement membrane to a certain extent by altering its dynamic structure. So these are really important proteins to appreciate in terms of how they regulate that specialized function of this component of the filtration barrier. So next slide. So this sort of shows it in a little bit more of sort of signaling detail. So that in red are the slit diaphragm components that are important and that we know can be altered in genetic forms of nephrotic syndrome, so that you can have mutations in those proteins. And then over the years, this has built up an intracellular picture of what happens to signaling pathways downstream. And a lot of it centers around the Rho GTPase protein, so the one shown in green. And these are well-known molecular switches that regulate actin cytoskeleton. So a lot is known about these proteins through study of, for example, cancer cells, where cell motility is very important. So it's interesting that the signaling pathways center largely around these proteins which regulate the actin cytoskeleton. And one reason for putting up a sort of complex diagram like this is to show that there are many potential breakpoints in the whole signaling pathway. It's like an electric circuit, if you like. So any breakpoint in that can lead to breakdown of that regulation of the actin cytoskeleton, which then leads to a breakdown of the shape and the dynamics of the cell of the podocyte. And that eventually then leads to what we see typically in electron microscopy when you do a biopsy in these patients, which is effacement of podocytes. So what people call sometimes foot process effacement. So effectively a loss of the shape of the podocyte and its foot processes. So next slide. And this is exactly illustrating that. So this is showing a normal podocyte on scanning electron microscopy on the left, and then the effaced podocyte, which is the kind of universal feature of any nephrotic syndrome, the breakdown of the podocyte and its complex structure, which, as I say, is regulated by those important proteins and signaling processes. Next slide. So that's again just illustrating that if the signals are disrupted, and they could be disrupted by many different means, then that structure of the cell is destroyed. Next slide. So what I've done here is to look at some of the key signals that the podocyte receives that actually makes a podocyte effectively. So tells the podocyte how to behave. And I've divided that into molecular signals at the top, and then soluble factors, so signals that come in from externally, extrinsic factors that affect the podocyte dynamically, and that's at the bottom. So the molecular signals, I've talked about some of the key proteins and genes, and I'll elaborate on that as we go along. So proteins such as these slit diaphragm proteins like nephrin, but also others, transcription factors, etc. And then signals from the basement membrane, direct signals largely through integrins, these proteins that link the cell to the basement membrane. And then soluble factors are very interesting in terms of disease also. So you can have paracrine factors from the local cells, the endothelial cells and the mesangial cells. And we know a lot about some of those signaling factors like VEGF and endothelin, but also circulating mediators, so things that are circulating in the plasma systemically. Now, clearly for nephrotic syndrome, there's a big story around immune-derived circulating mediators, and I'll talk about that as we go through. But there are also other key circulating mediators like insulin, for example. We've shown very clearly that insulin is crucial for podocyte health, and that could be very important in diseases such as diabetic nephropathy. And then there are circulating toxins like sugar toxin, and again, sugar toxin, which causes hemolytic uremic syndrome, directly acts on the podocyte, and we've got nice data that shows that, which I won't talk about today. So next slide. So those mediators will act via that signaling complex at the slit diaphragm. So there'll be receptors, probably in the slit diaphragm and elsewhere in the podocyte, that will inevitably act via some of those key signaling and specific signaling pathways that exist in the podocyte. Next slide. So this is where I think we are at the moment. If you just click on the next couple just to fill up this slide so that I don't have to do it individually. Yeah, that's perfect. So I think we're starting to reclassify nephrotic syndrome at a sort of initial level, starting with single gene disorders, so monogenic diseases, inherited diseases where you've got a mutation in a single gene that causes the disease. Then there's a separate group, which is the circulating factor diseases, which is the sort of term I tend to use. And this talks to those systemic factors that come from the circulation that then act on the podocyte. And if we can work out which patients, and these are probably immune-derived, but we don't yet know for certain, and if we can work out which patients have a circulating factor disease, it may turn out that there are other mechanisms that we haven't yet suspected that account for a proportion of patients. And all these patients will have different means of treatment, different modes of treatment that would be best for them. Next slide. So we're starting to sort of get two main mechanistic categories of nephrotic syndrome. The first, as I say, is circulating factor disease, probably immune-derived, and the second is monogenic disease. And currently, over the last sort of 20 years, probably, more and more genes have been discovered that cause nephrotic syndrome. And there are over 70 at the moment. And so the clinical question for the nephrologist is, who are the most relevant patients that we should test? What is the test we should be using? And also, are we missing patients? Are there genes that are not yet discovered? Next slide. So a lot of our information has come from patients like this. So this is a patient who had a congenital nephrotic syndrome, was born with nephrotic syndrome, a baby that Richard Coward, one of my colleagues, treated. This patient turned out to have a mutation in the gene for nephrin. So nephrin is a podocyte-specific gene. Next slide. And so that was one of the first genes to be discovered that causes nephrotic syndrome. And over the years, as I say, we've now got over 70. This isn't a complete list, but just an illustration of dividing the genetic causes into syndromic causes. So these are genes or proteins that are expressed in the cell, but are also expressed in other parts of the body, and therefore cause multi-system disorders. that includes the kidney. And you'll be probably most familiar with Allport's disease, for example, which, as you know, affects the ear and the eye as well, basement membranes, but lots of other syndromes that are associated with nephrotic syndrome. Next slide. And then there are also many genes that have been associated with isolated nephrotic syndrome. And again, this is a snapshot of them, but this list includes NPHS1 and NPHS2, which code for nephrin and podocin. Trypsi6, which is an important ion channel that sits on the cell surfaces, and it is also associated with the slit diaphragm, and so on. Next slide. And what these different genes tell us is important areas of biology of the podocyte that will inform us on what are the key, both key targets for therapy, but key areas of the cell mechanism and machinery that are important in maintaining the podocyte in its normal function. So I've mentioned already the slit diaphragm proteins, but there are also proteins that attach the cell to the basement membrane, so these integrin proteins or laminins as well, key parts of the basement membrane. The collagens, the collagen 4 genes, which cause Allport syndrome, they're also in that category. But there are also mitochondrial proteins. So certain mitochondrial proteins have been discovered that, if mutated, cause nephrotic syndrome, and other genes that are expressed in the nucleus that are called transcription factors that affect the expression of other genes. So there's whole areas of the disease biology, of cell biology, that have led us to help understand this disease much better. Next slide. So we're talking now about rare diseases and how do we find out. So I've given you a sort of a little overview of the biology that we need to understand, but how do we find out about what are the characteristics of the patients that we treat and learn about both their clinical features, but also the biological features, and particularly in, for example, genetics. So about 10 years ago, we set up RADAR, which is the UK Renal Rare Disease Registry. And the original target when we got the grant for this was 500 patients. And this has been hugely successful. So the RADAR now has over 26,000 patients, 36 different patient groups, which are rare diseases, of which nephrotic syndrome is one, and covers most of the renal units in the UK. So nephrotic syndrome was one of the pilot groups. We've now got, I think that number's out of date now, we've got over 3,000 patients recruited. So it allows us to study a rare disease with a level of power that we haven't been able to achieve previously. So next slide. So one of the pilot studies we did when we started recruiting patients was to look at steroid-resistant nephrotic syndrome in children and look at the genetics. And at the time, next generation sequencing was in its infancy, but we applied the sort of the iteration that was available to sequence 24 genes that had been published to be associated with SRNS. And what we found, the sort of long and short of it, was that it was a very reliable technique. It was inexpensive, it was highly reproducible, it was rapid and had good diagnostic potential. So we moved on as the technology improved to whole exome sequencing, which is sequencing every single exon of every gene in the human genome. And we've sequenced the first 200 patients. So that was the next step from this cohort of SRNS patients. And of course, that develops when you do that much sequencing on that scale, you get a huge amount of data. So we had to develop a filtering strategy for all the different variants that are discovered to work out which variants you see. Clearly, we all have lots of different variants as a population, but which variants may be responsible for the disease. Next slide. And this is, I don't want to sort of go through this in any detail, just to illustrate the breadth of different mutations we found even in a relatively small sample of almost 200 children. So there are about 17 or 18 different genes that we found to be mutated in this cohort overall, which are highlighted in purple. And it covers, quite a lot of the different areas of biology, if you like, of the podocyte that I've already explained. But also there were some that were sort of phenotypically unexpected. So for example, some of the collagen genes that cause Allport's disease these patients were presenting with FSGS and nephrotic syndrome predominantly. So there's an overlap phenotypically, which only if you start to sequence these patients, you start to find out. Next slide. So we can start to ask questions around the disease that we couldn't previously ask. So for example, what proportion of patients that we see in our clinic with SRNS have a single gene disorder, have a monogenic disease? And there'd been some previous studies, particularly from Franz Schaeffer's group in Germany and also Hildebrandt's group in the US, that had looked in the same way for genetic causes in this group of patients, but their groups of patients were highly enriched for familial cases, and they hadn't screened all the known genes in their studies. But nevertheless, they found a relatively high proportion of genetic causes. Our own study, we thought had improved on this because we actually screened every known gene at the time, and also our children that we screened were unselected. It was first come, first served from the registry. And what we found so far is that exactly a third of those patients have a single gene disorder. So a very high proportion of patients who present in childhood with SRNS will have a single gene disorder. Next slide. So we can look at various features of these cohorts. So for example, we can look at time to renal failure, can compare genetic versus non-genetic patients. And what you can see is that genetic group tends to progress faster, but we've refined that further, and I'll illustrate that as we go on with some of the data. Next slide. So in terms of clinical genetic testing, we now have the ability, with the development of these technologies, to put this into a clinical test that all clinicians can use. So we did this in collaboration with Bristol Genetics Laboratory. We've now got a gene panel with 70 genes on the panel. This slide's slightly out of date, but well over 1,000 patients have been tested so far, and it's a clinical service with a rapid turnaround that you can get a result between 4 and 12 weeks, and the cost is relatively cheap compared to sequencing all those genes individually, for example. So that with that kind of cost-benefit ratio, or changing of the cost-benefit ratio, you can now ask the question, which patients should be tested? And clearly, where we've shown that a third of children with SRNS have mutations, then it makes absolute sense that all children with SRNS should be tested. And that's now become the sort of part of our clinical algorithm in pediatrics. What about in adults? It's a slightly more difficult question, and it'd be interesting to know what your experience is in adult nephrology at the moment. But there are some now good studies suggesting that there could be as many as 10% or more of sporadic, non-familial patients who present with steroid-resistant nephrotic syndrome who have a mutation. So that, again, sort of shifts the balance, the cost-benefit ratio, so to speak, to suggest that certainly, if not all, a good proportion of adults who present should have genetic testing.
Would you mind if I asked a question?
Yeah, of course.
What are you taking as your definition of steroid-resistant nephrotic syndrome in children?
So we have four weeks of high-dose steroids plus or minus methylprednisolone at the end.
And then for adults, would you apply the same definition, or would you go to 3 months for adults?
So adults, we stick with what the adults do, which is 3 months. Yeah, exactly.
Thank you.
So next slide. So this is just an audit we did of the first 300 patients from that clinical genetic testing. And again, to illustrate that that a lot of different genes get picked up this way, and B, that there's this phenotypic overlap. So the red bars on the right-hand side show that we discovered, so the red is the patients who were referred with suspected Alport syndrome, but in blue for those genes with patients who were referred for SRNS, so nephrotic syndrome, but turned out to have the Alport's gene mutation. So that's, again, illustrates that phenotypic overlap that you wouldn't necessarily suspect clinically. Next slide. And also this has allowed us, by sequencing this cohort, to discover several new genes, either in collaboration with other groups or on our own. We've published these. So, and each new gene that is published gives you more clues about the underlying biological function. So some of these genes, for example, mitochondrial function, a new mitochondrial gene was discovered. and the SGPL1 gene showed a syndrome that had adrenal insufficiency in FSGS. So you know, some of these correlations are still puzzling in terms of biology as to why a gene that causes those two disparate effects, how that works. So it's leading us sort of more and more into understanding the underlying biology. Next slide. And this is just to illustrate the problem you have with sequencing, if you like, that when you sequence, you find variants and you find genes that you think may be causing the disease, but you have no way of knowing that for sure because there are so many different variations in genes. And so when you have a candidate gene, you need to prove the biology, the underlying biology, that this could affect the cell type that you're interested in. So concentrating on the podocyte then. So the nuclear pore complex genes was an unexpected group of genes that was found to be mutated in pedigrees of patients with nephrotic syndrome. And these are proteins that allow other proteins to come, they form a pore and they allow other proteins to go in and out of the nucleus. So a really good model we can use, relatively rapid, is in the fly. And it's called Drosophila. So the fly has a nephrocyte. It has a single nephron, which is equivalent, and the cell, the nephrocyte cell in the fly, is equivalent to the podocyte and expresses all the same proteins. And you can knock out genes in the nephrocyte relatively quickly. It's an experiment that just takes a few weeks. So we did this with one of the genes that we found from this cohort, NIP93, and showed, if you look at the very bottom panel compared to the panel above it, so that's the wild type above and the knockout below, showing the disruption in the nucleus that occurs, and you also get loss of nephrocytes, which is the middle panels. You can see the loss of those red cells when you knock out this gene. So that just illustrates a very rapid way of seeing whether the gene that you're interested affects the cell that you think it is having pathology in. These kind of, that's all right, I'm pretty much there. So these kinds of tools are what we use to try and discover new genes. So next slide. So this is a summary then of how we sort of classified or sorted out the classification of these patients with SRNS according to genetic sequencing. So we took all our patients with SRNS, we sequenced them, as I said, and we divided them into their clinical grouping, so primary steroid resistance or presumed, which is the ones who had a familial cause, and then secondary steroid resistance. So these are patients who initially respond to steroids and then become resistant sometime during the course of their disease. And we've all seen patients like this, and they're quite difficult patients to manage. And we sort of had the hypothesis that these must be different from primary steroid resistance because they initially completely respond to steroids. So they probably have an immune mechanism because of that response to steroids. So if you separate them out that way and then look at the genetic sequencing in those groups, what you can see is that all the patients with a genetic disease are on the left-hand side in that primary resistant group. So that's the group that has the genetic disease. And then on the right, the secondary steroid resistant group, none of those patients had a single gene disorder, suggesting that this is a completely different group of patients. And then if you look on the bottom row at their risk of recurrence of disease post-transplant, the single gene disorder patients have no recurrence of disease post-transplant. So that mechanism of post-transplant recurrence is not linked to having a genetic disease. However, on the right, the patients with secondary steroid resistance have a very high rate of post-transplant recurrence. And I'll show you some expanded numbers on that later on. So suggesting, again, this is a very specific group of patients that has a circulating factor that is probably immune-derived. There's still a big group in the middle with which are genetic testing negative, but also primary steroid resistant. So we don't know whether they have a single gene disorder. It may be there's a gene that there are genes we haven't discovered, and clearly that is likely to be the case in some of them. But also some of them will have an immune disease. And what's interesting is that that group in the middle, about 50% of them get post-transplant recurrence. So probably at least 50% of those patients have an immune-mediated circulating factor disease. So next slide. Sorry. Oh, yeah. So we're sort of moving on then from the genetic disorders to the circulating factor disorders, the patients that have a circulating factor disease. And this is a group that's more difficult to sort out and more difficult to identify. So are there biomarkers that will allow us to sift out and tell us which patients have a circulating factor disease? So I'm going to talk firstly about any clinical biomarkers, which I've already touched on, and then some of the biological biomarkers that we've been working on mostly in the laboratory. So next slide. So distinguishing clinically circulating factor disease patients. So this is really just expanding on what I've already alluded to. So the patients who get post-transplant recurrence, that's to me the archetypal circulating factor disease. So these are patients who get recurrence within minutes or hours of putting a new kidney into the patient, and they get massive proteinuria. And again, you've probably all seen this. They get massive proteinuria post-transplant very, very early on. There's no sort of doubt that there's something circulating that affects that new kidney. And we looked at the outcomes of 150 children with SRNS who'd been transplanted across 3 centres. And of those patients, 38% developed post-transplant recurrence, so roughly in the proportion that you'd expect. Next slide. And we hypothesized that the patients who had initial steroid sensitivity, so again, you call it either initial steroid sensitivity or secondary steroid resistance, we hypothesized that they have an immune-mediated disease that is more likely to recur. So of those 150 patients, 29 had this initial steroid sensitivity. And of those 29 patients, 26 and 90% of those patients developed recurrence. So this turned out to be a very effective biomarker, if you like, of circulating factor disease. And then the ones who didn't have initial steroid sensitivity, less than 25% of those recurred. Next slide. And looking at it the other way around, this was a historic group, so not many had had genetic testing, but 18 of 62 tested patients had a single gene mutation, and then a further 11 patients had extrarenal features suggestive of a genetic disorder. And only one of those patients, and this was a patient with a mild sort of mental retardation, developmental delay, so only one of those patients developed recurrence. So again, suggesting if you've got a genetic disease, you don't get recurrence, and it's a different mechanism. Next slide. And this is just a forest plot to show the odds for recurrence. So if you've got initial steroid sensitivity, which is down there at the bottom of that plot, you've got a very, very high odds ratio for recurrence, transplant recurrence, compared to a genetic disorder where you've got very low chance of recurrence. Next slide. So that's initial steroid sensitivity. What about your response then? Can you take that a step further and look at your response to your second line immunosuppression? So can we gather further clues from the way that these patients respond to their immunosuppression? So clearly when these patients are resistant to steroids, we start other immunosuppression on them, and usually it's something like cyclosporin, or it may be sort of other drugs, eventually rituximab and so on. So we wanted to look at our cohort and ask what proportion of patients have complete response to their intensified immunosuppression, and is there a difference in outcome between those who respond and those who don't? So next slide. So we searched out all the patients that had had complete genetic sequencing. So we wanted to filter out the patients who had a genetic disease for this study. So that was the cohort that I've already mentioned, but also a cohort of patients from the clinical genetic testing panel that was being done. So we ended up with about 250 patients that we could include that had had complete genetic testing done. Next slide. And then we looked at the medication response in these patients, again, through the registry, and we defined responses as complete response, which is a protein-creatinine ratio of less than 20, or a partial response of between 20 and 200 with a normal or a plasma albumin above 25. I'll concentrate on the patients with complete response. So this is, sorry, yeah, carry on to the next slide. So this is showing response to any medication. This is just illustrating that on the left, we looked at all treatments, and on the right, we looked at the first treatment that had been given after steroids. And essentially, it's showing that the black bars is complete response, that no drug has a better response than around a 25% response rate. Cyclophosphamide seems to be a bit worse, and rituximab is a little bit better, and I'll go into that in a bit more detail. So next slide. And then also it was interesting to see whether biopsy findings can predict your outcome or your response. And what we found was, and again, the solid bars are the complete response, is that there's no difference on in response according to what your biopsy shows. So particularly the FSGS versus the minimal change disease patients, they both had about a 20% response rate to treatment. Next slide. And I thought this was really interesting. So I'm just showing you a snapshot of the data, and it is published now. So this is your kidney survival. So the patients who go into end stage over a period of time, and they've got long follow-ups, a lot of these patients. So your kidney survival according to your response to your first immunosuppressive treatment. So the first treatment you get, which often is a calcineurin inhibitor, if you have a complete response to that, which is the red line, you do very well. So these patients have a very low attrition rate in terms of progression to end-stage renal disease. And also partial responders also largely do very well. So that was very interesting. And then there's a completely different group of the patients who have no response. Again, this is your first immunosuppression treatment. Patients have no response. The vast majority of these patients, so about 75% of patients, go on to end-stage renal failure over a follow-up period of over 15 years. So that suggests that there are two very different groups of patients and probably two different immune-mediated groups of patients. So clearly the patients who have responded, you would hypothesize that they have an immune disease that is responding. The patients who are what we call multi-drug resistant, the clue that we have that this is also immune disease is that group of patients, the ones represented by that green line, about 50% of those patients get post-transplant recurrence. Actually, that's not quite true. It was actually just over 60% of those get post-transplant recurrence. So the majority of those patients also have an immune-mediated circulating factor disease, but it's a disease that doesn't respond to therapy. So that's an interesting and very difficult group that needs to be sorted out. So next slide. So we're sort of starting to get to a point where we're adding some refinement to our reclassification of nephrotic syndrome. So you've got your single gene disorders, you can test that using next generation sequencing, and you can do some clinical predictions using family history, extrarenal features, but also initial steroid sensitivity as a discriminator. And then the circulating factor disease. As I say, there could be two or more types. You can sift those out using your initial steroid sensitivity if they happen to have that phenotype, but clearly there are patients who don't have that phenotype. And so you need a more biological test, we think, that you can do a blood test. If you've got a circulating factor, can you show from a blood test that that patient has that circulating factor? And the tests we've been using in the lab and trying to develop over the years is by taking that factor, taking the blood samples or the plasma exchange samples in the case of post-transplant recurrence, putting them onto podocytes in a dish and seeing what the response of the podocytes is, and do you get a deleterious response in the podocytes, particularly in some of those signaling pathways that I've mentioned right at the beginning that are mediated through nephrin, podocyte, and slit diaphragm complex. And I won't go through those in detail, but we've got quite a lot of information now that starts to help sift out some of those patients using tests on patient plasma. Next slide. So this is our tool, if you like, our toolkit for testing plasma samples. We take samples from patients, we put them on human podocytes, and we look at readouts such as localization of proteins, activity of certain proteins at the cell surface, and then phosphorylation. So these are intracellular markers of actin reorganization. So phosphorylation is a marker of actin reorganization, and also activation of certain receptors that we think could be specific for this particular circulating factor. So again, I'm not going to go through those all in detail, but these are stories that are actually very interesting and developing as we speak. Next slide. And I'm just going to show you some what we think are nice toys and nice pictures now, just quickly to illustrate how the technology has helped us develop this. So far, what I've described to you in the last slide was using podocytes in 2 dimensions on a dish, which may not be very representative of a human glomerulus. So we've developed recently this 3-dimensional, what we call a glomerular spheroid, by a technique of magnetic levitation. So this sounds like a magic trick, but it's not. It's what you do is that you put nanospheres, so nanoparticles on the cells, which allows the cells, if you apply a magnet to the cell culture plate, the cells then float in the medium, so they're no longer attached to plastic on the surface. So they can then self-organize, and what we've done is we put podocytes together with the glomerular endothelial cells together, and they self-organize. So the endothelial cells go to the middle, the podocytes come on the outside, and you get this lovely sphere that is the same size as the glomerulus, with the podocytes showing foot processes, etc. Next slide. And what they do, and what's shown here in blue, this is a cross-section of these spheroids. So they make a basement membrane. So they make a basement membrane with all the right proteins in them. And we can test those. So we can now test our plasma samples on these spheroids and count, for example, the number of podocytes that fall off the spheroids in response to the disease plasma. So on the top, you've got relapse plasma. So this is active plasma post-transplant relapse that you put on the spheroids, and you can see there are fewer green cells there, which is the podocytes, compared to remission, which is just below it. And then on the very right-hand side, we've added a modulator so we can test drugs. We've added an antifibrotic drug in this instance that has actually rescued some of that podocyte loss. So you can start to test drugs that may be useful in a clinical setting. Next slide. So I've sort of illustrated to you where we are so far in terms of the registry and how we've collected the patients and the samples and some of the research we've done with that. The next phase at the moment that we're developing is called Nurture, which is actually an infrastructure of dedicated renal research nurses to recruit patients to cohorts, and also at the same time collect detailed biosamples with what's very important is a meticulous and very consistent protocol. So these are patients who, from taking the blood to aliquoting and freezing at -80 is done within a maximum of 2 hours, so these samples don't degrade, and that's really important when you're doing research. And this has been funded initially by industry, because industry is very interested in this approach as a way of achieving their precision medicine goals. And so far we've collected 3,000 CKD patients, and we're up to about 600 odd nephrotic syndrome patients. Next slide. I'll skip through the next one just in terms of time. So we've got funding. Sorry, just go back to that one. Yeah, so we've got funding through the MRC to actually now use the samples from the Nurture cohorts to do these detailed analyses. So not just gene sequencing, we can do transcriptomics, which is looking at RNA expression. We can do proteomics, looking at protein expression, and we can use the plasma samples for some of those cellular and the spheroid readouts that I've described. So I think that's really exciting for taking this forward, and hopefully in the next few years we'll learn a lot from these kind of analyses. So the final few minutes, we can skip through actually. So the next, just keep skipping. I'll skip this particular study, which is interesting but slightly more in-depth biology. Yeah, keep going. I'll tell you when to stop. there. So yeah, just stop there. So I've talked about. Sorry, just go back one. I've talked about the kind of the ways that we're classifying these patients and circulating factor disease. And it may be that in circulating factor disease, you can apply specific treatments according to what subgroups these patients are in. So it may be that rituximab is better for some patients than others, and we'll have biological markers for those. But then you've got the genetic disorders where we don't yet have any treatments at all. So next slide. So one very promising avenue of treating genetic disorders is using gene therapy. And this has been spectacularly successful in certain diseases so far. So for example, in haemophilia, you can get sort of pretty much complete rescue of disease by putting the gene of interest back into the liver cells. So the gene that's missing is put back into liver cells using a vector, and it's a viral vector, so it's adeno-associated virus. So that's the way to target your gene to your cell of interest to rescue the disease. Now the problem in the kidneys is that how do you target the right cells and the right genes in an organ that's very complicated and has lots and lots of different cell types? So the way that we do this, so the hypothesis is that podocytes, because they have these very specific genes like podosin and nephrin, you can target to the podocyte using the promoters of those genes, so the specific promoters that allow those proteins to only be expressed in the podocyte. So we sort of tested the hypothesis, if you like, that you can use AAV with a podocyte specific promoter to target your gene of interest into the podocyte. And the reason the podocyte is, in theory, a really good target for gene therapy is that podocytes are terminally differentiated cells. So once you can get your gene into the podocyte, it should stay there, in theory, for life. So next slide. So we did this first with the podocytes in a dish. So we took podocytes, we made a construct with a podocyte-specific promoter, an AAV construct, and then we, as part of the cassette in that construct, or one of the cassettes in the construct, we put the podosin gene. So you can put your gene that you want to express into the vector, the AAV vector, and with a podocyte-specific promoter. And what this is showing is just in the panel in green shows that you've got nice specific expression in a podocyte of this is actually just showing a green fluorescent protein as your protein of interest that's being expressed in the cell. Yeah, next slide. So what we did is we took podocytes. Yeah, let's go to the next one. So we took podocytes from a patient who had a mutation in the podosin gene. So we grew those podocytes in a dish. And what we see with those podocytes is they functionally, they have a defect in adhesion, so they don't stick very well to the dish. And so we used our gene therapy vector to rescue these podocytes with normal podosin. This bar graph just shows the rescue of that adhesion of the cell, the adherence, which is shown on the y-axis. So the wild type is on the left. In the middle is your mutant cells that have less adherence, and on the right is the cells that have been rescued with wild type podosin. So that shows proof of principle that you can rescue the function of these cells using a gene therapy approach. Next slide. So the next stage is to take this to an animal, and what we did is we made some constructs to do this sort of gene therapy in a mouse. So the mouse we used, it was an inducible knockout of the podosin gene. So this is a mouse that gets very significant proteinuria when you knock out the podosin gene in podocytes. And we made various constructs, and again, you don't need to know the details, but what we used was either human or mouse podosin, depending on whether we're testing human cells in a dish or the mouse model in vivo. And we used two different promoters. One was a mouse nephrin promoter, and the other was a human nephrin promoter, just testing them side by side. So next slide. And what we did is we injected, so the other technical problem to solve is how do you get your gene therapy construct to the podocyte. So the ideal way would be a direct renal artery injection, which would actually prove to be pretty much impossible in our hands because the renal artery in a mouse is so small. So we ended up doing a tail vein injection in these podocin knockout mice. Next slide. And this is just a summary of the data. So what this shows is, and clearly we're looking at proteinuria as one of the main readouts, so the graph on the left, you can see the saline treated mice, which is the control mice who have effectively no gene therapy treatment, get massive proteinuria, the albumin-creatinine ratio, by day 42. And then the mice treated with the vector, and this is just comparing the mouse nephrin versus the human nephrin promoter. So there's no difference between the two promoters. They get much less proteinuria, almost down to normal levels. And the graph on the right just is a Kaplan-Meier curve just showing survival. So again, the mice in green is the mice who've been saline control treated. So these are the mice who have podocin knockout and no treatment. And then in red and blue are the two different promoters, but this is the gene therapy treatment. And what you can see is sort of 60% plus long-term survival of these mice. The mice don't die at all. We had to cull them after a year. So we've got pretty much excellent therapeutic proof of principle that this gene therapy approach works. Next slide. So I hope I've sort of shown you overall how we're sort of moving to a precision medicine approach to nephrotic syndrome by a kind of a variety of different means that come together. So deep phenotyping via patient cohorts, genotyping through these gene panels and exome sequencing, and then biological and clinical biomarkers. And that eventually should lead us to the point where we're doing clinical trials on stratified groups of patients rather than the group as a whole. And these trials will be for treatments that are aimed at the specific underlying molecular mechanism of that disease. And a really nice illustration of that is the gene therapy approach, where you're treating each specific gene according to each specific patient according to the gene that is disordered in those patients. So final slide. And just move to the next slide. Oops, it's gone back one. Yeah, so that's just to sort of thank everyone who's been involved. Lots of people in the lab in Bristol who've done this work over the years, various collaborators around the country and around the world, and of course lots of funders who've been involved with this, and hopefully we'll sort of continue to move it forwards. So that's the end of my talk. So thank you very much for listening, and very happy now to take any questions or move to whatever the next stage of the session is.
I'm just going to start while people are getting ready. That was a fantastic presentation. I think as adult nephrologists, unfortunately, one of my day jobs is to do transition care. So I get quite a lot of the pediatric patients coming over to me with many, many years of steroid-resistant nephrotic syndrome, kind of end stage relapse post-transplant. And a couple of the cases that I'm going to present today or get discussion around relate to those cases. And we have, I suppose, a pretty tough time in managing those cases. I'm interested in your experience. Obviously, you're working in the pediatric field, but I look after a separate cohort of patients. I do high-risk maternal medicine as well, and I have a fairly sizable cohort of women now who develop nephrotic syndrome towards the end of pregnancy and have remarkably difficult disease to treat subsequently, where their first episode is steroid responsive, and then very rapidly they become steroid resistant. And I'm speculating that something about the pregnancy altered their immune profile in some way to allow them to get nephrotic syndrome and make it remarkably difficult to manage. And I'm just wondering if that is something that you have come across in your research field.
No, that's very interesting. Clearly, from a clinical perspective, we don't see that age group, so I don't see them personally. And usually in pregnancy, we're concentrating on preeclampsia and the mechanism behind the proteinuria that you get in preeclampsia. So actually, I'm very interested to hear that experience. I don't know whether other people have seen that as well. It's not something I've particularly heard of before.
Yeah, it hasn't been, I suppose, particularly described, but it's very striking. I certainly can think of 4 patients straight off where nephrotic syndrome developed by around week 30. They all had biopsy-proven disease. Each one of them remitted fairly rapidly with steroids, but then relapsed again very, very promptly, and pretty much either became steroid dependent or steroid resistant. And in one case, one patient went on to have a relapse immediately post-transplant. So it just strikes me that something about the immune environment within pregnancy makes them and makes their disease a little bit different.
Yeah, that's fascinating. It'd be interesting to investigate those further. I'd love to have some blood samples from them.
Yeah, I was just thinking that. I mean, they're a very interesting cohort. So,
do they ever respond to the second line? Do they respond to tacrolimus or?
So they had brief responses, and then third line rituximab. 2 of them have had fairly durable responses, and the other person had a protracted response. But it was a difficult journey to get them to remission and a much more protracted course. Okay. So if you are, I mean, they've always piqued my interest as to there has to be a mechanism underlying this, and making them so atypical in their behavior.
Yeah, well, maybe we should talk about that offline. Yeah. I'm very interested to know more about this.
So this was just to fill a little time while I'm waiting for people to come up with either some comments or whether they wanted to send in some queries through chat, etc. Because I'm conscious that Mon may actually want to go home and have his dinner.
That's all right. I can stay around a little bit. It's one of my favourite topics. So always.
Yeah, I love nephrotic syndrome.
Moen, that was a great talk, and I think it really distilled what the experience is for adult nephrologists, that we have beautiful descriptions, poetic even, but we don't have diagnoses, and that unlike other specialties, hematology, oncology, who are putting everyone into trials, that really, I don't know that we're contributing much in terms of how to better manage these people, because we seem to be making it up every time without trying to make a proper diagnosis, and seeing what does work and what doesn't work. So your talk was really interesting.
Yeah, and I'm desperate to get away from this blunderbuss approach. But clearly, these are rare diseases, and it's difficult to start to do trials on small groups of patients. And pharma are very interested at the moment because of all the biology that we've learned in actually trying. There's quite a lot of potential new treatments out there. In fact, yesterday, Vifor, one of the sort of pharmaceutical companies that being doing a trial in a chemokine inhibitor, announced that their trial had failed in phase 2, which very disappointing for them, but also probably not surprising because they had real problems in recruiting and they didn't stratify at all. So I don't think they had the right approach. But we need to get much more sophisticated about this, and hopefully we're moving in that direction. But it needs all the sort of clinicians who are involved to be part of it, I think, because it's not going to be able to be done on a small scale.
Moen, may I ask you a little bit more about this kind of the holy grail of the circulating factor that may contribute to the kind of almost instantaneous relapse of nephrotic syndrome in some patients? Yeah. This is a soluble factor. We think it's a removable factor because we see response with plasma exchange. Is that something that you can speculate on further? Because you said you felt it was something within the immune system. I mean, we obviously thought that years and years of separating out the kind of whatever was plasma exchange was going to allow us to identify this compound, and we haven't really progressed hugely.
Yeah, I've always said that I'm not going to speculate too much because so many people's careers have crashed on the rocks of trying to find what the circulating factor is. We do have our own favourite candidates. So we're working. So we've worked from looking at it from the other direction, if you like, and looking at what's happening to the podocyte in response to circulating factor, and then generating clues going backwards as to what it could be, what factor could be causing that response. And we came up with a hypothesis that it could be circulating proteases. So the plasma is full of proteases and antiproteases. This is a very tightly regulated system of proteins. So the ones that you may be familiar with are things like coagulation factors, thrombin, antithrombin, and so on. These are all proteases and antiproteases that are kept in check by the balance of their cognate, antiproteases. So, and there are dozens of these, if not more, circulating in plasma. So we kind of thought, well, maybe there's an imbalance of proteases that is causing a receptor. So proteases have receptors, and there's a receptor on the cell surface they're called PARs, protease activated receptors. So the podocyte has receptors for proteases. So we've done a lot of work which suggests that PAR1, the main receptor, has effects on mediating the response to plasma. So that's our current. We've actually got a really nice mouse model now where if you overactivate PAR1 just on podocytes, you get exactly the FSGS phenotype. So we think that's promising, but as I say, I'm not going to say that that's the right thing because I'll probably crash on the same rocks. So until we have the kind of enough evidence to suggest this is the right way to go, at the moment it's a nice biological pathway that we can face up and follow.
So may I ask you one final question? In terms of where your samples, oh, no problem.
Sorry, I'll mute.
So just in terms of the sample collections that you have, how easy is it for other units to access the kind of the genomic sequencing that you're performing? Is this only as part of a research database, or is this actually something that you offer as an entity that can be purchased from other units?
So the gene panel sequencing, where they sequence all the known genes, that's available as a clinical service. So anyone around the world can just send a form and a sample to Bristol Genetics Labs, and they'll do it for you for, I think it's about £600. The whole genome and the whole exome sequencing that we're doing is part of the research project. So that's coming within both those Nurture and the Nephros, the radar cohorts that we're collecting. So that's more of a research tool that we don't guarantee a result from that clearly, but when we do find results, we communicate that to the clinicians.
Okay. Does anybody else want to ask a quick question before we move on? Mark, had you anything you wanted to say?
No, I'm fine, Kate. I was just wondering, in the interest of time, if there's no other questions, we might have a breakout room session.
Yep, perfect.
Unless anybody has a burning question they want to ask, but I often find that it's easier within the breakout session to ask questions. It's a bit intimidating in the wider group. So what I've done is I've created 2 breakout rooms, and don't blame me for the room you get assigned to, but we've got one with Dr. Wallen, the other one with Dr. Griffin. So I'm going to open those rooms now. And so you should, in theory, get an invitation to join each room. If you can accept those, that'd be great. So just, Brenda, there you go. Brenda, you just need to join yours, okay. Okay, so it's just us 2 Moan left. So,
okay, what do I do now then?
So it's up to you, but I just didn't want to put any pressure on you to hang around.
Yeah, well, I'm happy to hang around for a little bit. So I might, I'll certainly go into one of the rooms and then.
Sure, yeah, okay. Well, I can put you in. You can leave anytime you want, just press the leave thing.
Yeah.
I'll put you in one of the breakout rooms. If you want to leave and pop into the other one and say hello, that's fine as well.
Okay.
I'll be on here just kind of mediating.
Yeah.
And thanks very much again for doing that talk.
It's a pleasure. I'm impressed at your IT skills, Mark. I need to learn from you.
Well,